My name is Claire Healy. I am a genetic counselor in the Smilow Cancer Genetics and Prevention Program and one of the co-managers of the genetic counselors. I first want to thank you all for joining us tonight. It's my pleasure to moderate tonight's event, and it's wonderful to see so many people who have joined us. We're here tonight to learn about cancer risk factors and options for cancer prevention. During the presentation, please feel free to submit your questions through the Q&A feature at the bottom of your screen. We'll hold the questions until the end, but we'll try and answer as many as possible. And I'd first like to just start by doing some brief introductions of our speakers. We have Tanaya Shroff, who's a genetic counselor in the Smilow Cancer Genetics and Prevention Program. She holds a bachelor's degree in biotechnology and graduated from the Joan H. Marks program in human genetics at Sarah Lawrence College with a master's degree in genetic counseling. She joined the Smilow Cancer Genetics and Prevention Program in 2019, and she currently sees patients in New Haven and on the St. Raphael's campus, as well as at St. Francis Hospital in Hartford. She enjoys working with her patients to help ensure they understand their risk for inherited cancer syndromes and have access to genetic testing. And we also have Dr. Veda Giri, who is a medical oncologist with a specialization in clinical cancer genetics. She's the division chief of clinical cancer genetics for Yale School of Medicine and assistant director of clinical cancer genetics at Yale Cancer Center. Dr. Giri's research interests include developing the field of genetic counseling and genetic testing for inherited prostate cancer. She's the principal investigator of multiple grant-funded prostate cancer genetics evaluation studies spanning genetic counseling, genetic testing, disparities, behavioral science, and implementation research. And Dr. Giri received her medical degree from Sidney Kimmel Medical College and completed her residency in internal medicine and fellowship in hematology-oncology at the University of Michigan. She then completed advanced training in molecular cancer genetics and cancer risk assessment at FAQS Chase Cancer Center. Dr. Giri serves on several national committees, contributing her expertise in cancer risk assessment and genetics at a national level. So thank you both so much for joining us tonight and for speaking with us today.
Wonderful. Thank you so much for those introductions. And it's certainly a pleasure to be here today and to co-introduce as well. So that is Claire Healy, who is one of our co-managers in the Cancer Genetics and Prevention Program, a lead genetic counselor, and is a true leader in our team. And I'm thrilled to be here today and to introduce our main speaker, who is Tanaya Shroff, a genetic counselor at our Cancer Genetics and Prevention Program at Yale and Smilow Cancer Hospital. So what we're going to be talking about today is understanding your cancer risk and options for cancer prevention. This is an area that we deal with on a very deep level with many patients a year, thousands of patients a year. If you can go to the next slide, please. And we have a robust genetics team that is growing in order to accommodate the needs of our patients in New Haven and across really the state of Connecticut and even into Rhode Island. Our genetics team is shown here that includes genetic counselors, dedicated scheduling and intake staff, genetic counseling assistants, physicians, and physician office liaisons who help with communication of our team to the physicians who refer to us and other providers who refer to us. So we're happy to answer questions from our patients and from our providers in our region. Next slide, please. So the goals for our program today are going to be covering a wide spectrum of topics, but all related to this area of cancer risk and options for cancer prevention. So we're going to be covering background on cancer risk factors. This is going to start with actually talking about lifestyle factors and exposures, and then going into the hereditary factors. So we do see patients, obviously the main focus is for genetic counseling and testing, but a major important thing to think about are other risk factors that could raise the risk for specific cancers. We're going to go into then when to suspect hereditary cancers in families, and give you an overview of genetic testing, what it is, what the process involves, and then how genetic results can inform cancer screening, risk reduction, and treatment. And definitely we'll be able to give opportunities for questions. So happy to have your questions coming forward as well. Next slide, please. And just as a reminder, February is National Cancer Prevention Month. So this is a really key time to bring this back into the forefront and raise the public's awareness about the importance of what we can do to help lower our risk for cancer, lead a healthy lifestyle, and potentially think about things like what's our family history. And if we need to see a genetic specialist, that's part of the whole theme of prevention for cancers. And so we're excited to be doing this Smilow Shares event in National Cancer Prevention Month. So with that, I'd like to turn it over to Tanaya Shroff for the remainder of the presentation.
Thank you, Dr. Giri, and thank you for coming and joining us tonight, everyone. We will be talking about factors for cancer prevention, focusing on both non-hereditary and hereditary factors. And as Dr. Giri mentioned, we'll start by discussing some basic information about cancer, followed by non-hereditary factors, and then lastly, focusing on how genetics and genetic testing plays a role in understanding cancer risks and in cancer prevention. All right, so let's start with some background information. So based on the current data that we have, we know that about 1.7 million people are diagnosed with cancer each year in the US. And we will see that about 1 in 3 people will develop cancer in their lifetime. So if we look at some of the estimates for the year of 2023, for males here on the left, about 288,000 men will be diagnosed with prostate cancer in 2023, making it the most common cancer for men to develop. And on the right side here, we look at 297,000 women are estimated to develop breast cancer in 2023, making it the most common cancer for women to develop. But the question is, are all of these cancers we see hereditary? And the answer is no. We can sort of broadly divide cancer into 3 categories here. And so the first one on here, which a lot of times people are surprised to hear, is that majority of all cancer, so approximately 70%, is sporadic. That just occurred by random chance. And this could be due to a combination of factors like lifestyle factors, environmental factors, the process of aging itself, and there are a lot of other factors that may be contributing that we just don't know about at this time. And then we have this about 15 to 20% of cancer, which we refer to as familial cancers. So there may be factors that families share, like families share environments, they share diets, lifestyle, even smaller genetic markers that maybe we just can't identify today. And that might result in an increased risk of developing a certain type of cancer in that family, but we're not able to pinpoint those factors at this time. And then we have this about 5 to 10%, so relatively really small proportion of cancer, which is hereditary. And this is a category that we will focus on in the second half of our talk. Okay, so let's start by discussing some basic cancer prevention. So we'll focus on factors that we may be exposed to or kind of are a part of our lifestyle. And some of these are potentially modifiable. And we can sort of divide these factors that are associated with cancer risk into 3 broad categories. So the first one is lifestyle risk factors. The second one is environmental risk factors. And then we have this other miscellaneous category. And in the lifestyle risk factors, some of the examples would include tobacco use, alcohol consumption, diet, having excess body weight, and physical activity. Environmental risk factors could include sun exposure, virus infections, and even having occupational exposures. And then this other category comprises of a bunch of things such as the aging process itself, certain medical conditions, hormonal use, and of course, some unknown factors. So let's look at some of these factors in more details, kind of discuss how these factors influence cancer risk and how can we modify them to assist with reducing the risk of developing cancer. So lifestyle-related cancer risk factors. And the first one on here is tobacco use. So tobacco use is the leading preventable cause of cancer and cancer deaths. Cancers linked to tobacco use make up to 40% of all the cancers that are diagnosed in the US. And the first thought is usually tobacco use is associated with lung cancer, but it's in fact associated with about 12 different types of cancers. So not just lung, but also cancers of the mouth, the throat, the voice box, the esophagus, stomach, kidney, pancreas, the liver, bladder, cervix, colon and rectal cancer, as well as a type of leukemia. So importantly, quitting tobacco use at any age can reduce the risk of getting or dying from cancer. And getting screened for cancer can lead to fewer people getting or dying for some tobacco-related cancers, such as cervical cancer, colorectal cancer, and lung cancer. The second one on here is alcohol consumption. So alcohol consumption has been linked to an increased risk of mouth cancer, throat cancer, called the pharynx, voice box cancer, called the larynx, esophageal cancer, and liver cancer. And to reduce the risk of alcohol-related harms, adults of legal drinking age can choose not to drink or to drink in moderation. And what does that mean, to drink in moderation? So moderate drinking is limiting intake to 1 drink or less in a day for women, so up to 7 drinks or less for women in a week, and about 2 drinks or less in a day for men, so 14 drinks or less than that per week for men. And heavy drinking is drinking about 8 drinks or more per week for women and 15 drinks or more for men. What is noted is that overall, the amount of alcohol someone drinks over time, not really the type of alcoholic beverage, seems to be the most important factor in raising the risk of cancer in individuals. The third one on here is excess body weight. So being overweight or having obesity does increase your risk of getting cancer, and it's linked with a higher risk of getting about 13 different types of cancers. So it's associated with an increased risk of colon, endometrial, postmenopausal breast cancer, kidney cancer, and esophageal cancers. And obesity may also play a role in other cancers, including prostate, liver, gallbladder, stomach, pancreas, and thyroid cancer. You can aim to achieve a healthy weight by making healthy lifestyle choices, and you can reduce your risk of obesity-related cancer by following a healthy eating plan and getting regular physical activity. So rolling right into physical activity, greater physical activity is associated with decreased risk for many different types of cancers. But the most compelling data that we have are in association with the reduction of colon cancer risk and breast cancer risk. So physical activity is defined as any movement that uses skeletal muscles and requires more energy than resting. So it could include things like walking, running, dancing, performing household chores, exercising, or engaging in any sports activities. But it can be hard to incorporate that into your daily schedule or daily routine. So we can start small. Park your car a bit further from work each day. Use part of your lunch hour to walk around the block, taking the stairs, and even adding physical activities you enjoy, like dancing or walking, to your family and social life, or doing some physically active yard work, for example, gardening or raking. But before you take up any strenuous physical activity, we do encourage you to discuss these plans with your healthcare providers. Then we have diet. So a variety of specific dietary factors, vitamins, and supplements have been studied with regard to their possible association with either increased or decreased cancer risk. However, most have not been consistently shown to affect risk, but nevertheless, we do recommend people eat a diet rich in fruits, vegetables, and whole grains, and a diet that is low in saturated or trans fat, red meat, and processed meat. Okay, so moving on to environmental cancer risk factors. So sun exposure is a big one. So radiation from sun exposure is the primary cause of skin cancers. And these skin cancers can include melanoma or non-melanoma skin cancers like a basal cell cancer or a squamous cell skin cancer. The total lifetime sun exposure does increase the risk of developing skin cancer. And it's thought that this risk may be associated even more significantly with having repeated blistering sunburns. Now, in addition to direct radiation exposure from the sun, UV exposure from tanning beds also significantly increases the risk of melanoma, with about a 75% increase in risk in individuals who started using tanning beds before the age of 35. So it's important for all individuals to avoid using tanning beds, limit their sun exposure, wearing hats, sunglasses, and protective clothing when you're out in the sun, using a broad spectrum water resistant sunscreen with a sun protection factor, also called SPF, of at least 30 on a year-round daily basis. Another one that's environmental is virus infections. So a lot of people are surprised to hear that an estimated about 17% of all cancers are due to infections. And many associations between the specific infection and a cancer has been established. So for example, a lot of people might be familiar with the human papillomavirus, or HPV, which is associated with cervical cancer and other anogenital and head and neck cancers. We know that hepatitis B and hepatitis C infections are associated with liver cancer. And then human immunodeficiency virus, or HIV, is associated with a cancer called Kaposi sarcoma, as well as non-Hodgkin's lymphoma. And most of these infections are spread through blood or bodily fluids, and thus are often spread through sexual contact, including oral sex. Therefore, methods of prevention include always following safer sex practices, needle exchange programs, and regulation of tattooing. In addition to doing that, vaccinations for HPV and hepatitis are available. And in fact, a quadrivalent HPV vaccine is recommended for girls and boys aged 11 to 12, but it can be given as early as age 9. And then some of these other factors that influence cancer risk. So one is asbestos exposure, which you may be, or people may be exposed to as a part of their work environment, or even in spaces that they're living in. So it has been associated with adverse health effects such as lung cancer and mesothelioma. And so some examples of products that may contain asbestos include automobile brakes, insulation materials, and cement. So if people are directly working with asbestos in their work environment, or live in an environment, or are in an environment where there's free asbestos fibers, that can increase the risk of developing certain cancers. And the others that we mentioned earlier, aging process, certain medical conditions, hormonal use, and of course, there are some unknown factors that maybe we just haven't identified yet that influence the risk of cancer. And so to summarize this part, here are some things we could do to reduce our cancer risk. So avoid tobacco, be physically active, maintain a healthy weight, limit alcohol where 0 is best, protect against the sun and avoid tanning beds, protect against sexually transmitted infections, get vaccinated against human papillomavirus, get regular screening for cancer that's routinely recommended for anyone in the general population, such as mammograms and colonoscopies. Okay, so we've been talking about factors associated with cancer risks, which don't include the hereditary factors. So let's switch gears and discuss how cancer can be hereditary and what can we do for cancer prevention in those cases. So I wanted to start by discussing what we look for in an individual's personal or family history while assessing the risk for hereditary cancer, or what you could try to look for in your own history or your family history. And these factors are referred to as red flags for hereditary cancer. So the first one, and an important one, is an early age of onset, which is defined as typically being prior to age 50. Another one would be multiple cancers in the same person, such as an individual has been diagnosed with 2 breast cancers. Multiple family members with same cancer. So maybe we are seeing a person with kidney cancer who has 3 other close relatives with kidney cancer. Those would be red flags. Or multiple family members with related cancer. So maybe we are seeing a person or their family where there are instances of breast, ovarian, and pancreatic cancer. Or there are multiple people in the family with colon and uterine cancer. So cancers that are related to each other can also raise suspicion. We also look for rare cancers, so cancers that are not very common in the population, such as pancreatic cancer, ovarian cancer, or male breast cancer, so they're just very unusual. And of course, if an individual in the family has already been diagnosed with a known hereditary cancer syndrome through genetic testing, that's a big red flag. And lastly, ethnicity. So certain ethnicities or ancestries like the Ashkenazi Jewish ancestry are red flags because we know that the prevalence of certain hereditary cancer syndromes is higher in those ancestries or ethnicities. So we've identified red flags, but what do we do with those? And how does genetic testing really help identify cancer risk? And before we jump to that part, let's take a couple of minutes to discuss what genes are and what is genetic testing really looking for in your genes. Okay, so genes are body's instruction manual that control certain functions in the body. So they tell our body how to work. And we have genes for our eye color, we have genes for our hair color, and then similarly, we have genes called the cancer prevention genes, which are there in our body to protect us from developing cancer. And genes come in a particular order of letters, as you can see here, so they have to be spelled a certain way to be able to work and function correctly. Now, we inherit these genes from our parents, and they're present in pairs because we get one copy of each of our genes from our mother, and we get the second copy of that gene from our dad. Now, what a genetic testing really looks for in your gene is a mutation. So that's what the genetic test is trying to find out. Mutation is like a spelling error in the gene. It's a change in the order of the letters that's different from the way it's supposed to be spelled out. And the mutation does not allow the gene to work correctly. So when a mutation sort of happens in a cancer prevention gene, it results in an increased risk of developing cancer for that particular individual. And mutations can be of two types, and it's important not to get confused between those two. So the first type is called a somatic mutation. So somatic mutation is a change in the gene that occurs after conception. So over time, people can acquire mutation if they're exposed to certain things like UV rays, for example, that can result in these changes in your genes, but they are only located to the cancer cells. And so they're not present in the germ cells, which is the egg cells and the sperm cells. And since they're not present there, they're not passed down to children. So somatic mutations are not the type of mutations we are usually discussing when it comes to genetic testing for a hereditary cancer syndrome. But on the other hand, germline mutations. So these are changes in the gene that is inherited from the egg cell or the sperm cell during conception. So while you're conceived, you inherited these mutations from your parents. So germline mutations are incorporated into the genes in every single cell of the body, including the egg cells and the sperm cells, and therefore they can be passed down to children or can be inherited. And so these are the kinds of mutations we are looking for while discussing hereditary cancer syndromes with patients. And since there are two types of mutations, we have two types of tests. So the first one is called somatic genetic testing, which we're currently discussing, and it's much different from germline genetic testing, which we'll focus on in the next few slides. But somatic testing looks at mutations in the genes of an individual's somatic cells. So these are the cells that make up and are limited only to the cancer. And this test is typically performed to guide the diagnosis and treatment of cancer. So sometimes we have patients who themselves had this test or their family members have had this test, but it's important to know that it's not really looking for a hereditary predisposition to cancer, but more so for the diagnosis and treatment of that person's cancer. And the mutations identified through somatic genetic testing are not necessarily present in every single cell of the body. And therefore are not necessarily inherited. And this type of testing is often ordered by physicians rather than genetic counselors because they are the ones who are treating and diagnosing patients with cancer. Okay, so this is sort of our focus when it comes to hereditary cancer syndromes. So germline genetic testing looks for mutations that are present in every single cell of that individual's body. And the mutations identified through germline genetic testing can be passed down to an individual's offspring and can provide information about inherited risk of cancer. So this is the type of test that we would offer patients during our appointments. So when patients come in for a visit, they're sometimes surprised to hear that there are different options for germline genetic testing. And so I have 3 listed on here. So first one is called the single gene test. And as the name suggests, this test analyzes a single gene or a specific mutation in the gene. So this kind of testing is typically used when there is already a known family history of a hereditary cancer syndrome. So when we see patients, let's say, the patient's mother has had genetic testing already and there is a known mutation that was identified through her testing, this kind of test might be a more optimal option for that patient we're seeing. The second is called the cancer site-specific panel test. So this kind of test analyzes multiple genes related to a specific cancer type. And this is typically used when there is a personal and/or a family history of the same type of cancer. For example, if you're seeing a patient who has a personal history of prostate cancer and has 3 other close relatives with prostate cancer, we would kind of discuss the option of doing a panel that includes all prostate cancer genes on there. And then lastly, we have the expanded panel testing, which analyzes multiple genes related to several types of cancers. And this is typically used when there is a personal and/or a family history of several types of cancers, which sort of all raise suspicion for a hereditary cause. So if we meet a patient where in the family there is instances of breast, pancreatic, colon, uterine, multiple cancers, then this might be the option that would provide them with the most information. Okay, so we've talked about what germline genetic testing is and what are the options. But how is this genetic testing performed? Patients usually have questions whether this is going to be very invasive. So genetic testing is actually most often performed from a blood sample, and it may also be performed using a saliva sample. And then patients also have questions about the cost of such testing. So most insurance companies cover the cost of genetic testing, especially for those who have a personal and a very strong family history of cancer. Of course, the exact cost of tests differs based on the individual's personal and/or family history of cancer and the specific health insurance plans. There are factors that are sort of beyond our control, like co-pays, deductibles that may factor in or play a role in determining the cost of the test. But some laboratories offer the option of genetic testing for an out-of-pocket cost of approximately $250. So for whom genetic testing is clinically indicated and they're having a hard time receiving coverage for this test from the insurance company, those patients or individuals might choose to utilize this option for genetic testing. Okay, so I just wanted to introduce a word here, which is previvor. So previvors are individuals who know that they have a higher risk of developing cancer, but have not developed cancer yet. So if we meet with a patient who has no personal history of cancer, they undergo genetic testing and are found to have a mutation, which increases their risk of developing cancer, those are the individuals who we would refer to as previvors. So keeping that word in mind, let's see how this information about having a hereditary cancer syndrome help in terms of cancer prevention. And we can divide this broadly into 4 categories. So first is it helps understand cancer risks. It can help guide medical management. It can also help guide treatment and surgical decisions. And lastly, it can help identify at-risk family members. And let's look at each of these in a bit more detail. So starting with help understand cancer risks. So identifying a germline mutation in a cancer gene can help clarify the specific lifetime cancer risk for an individual. It also provides an explanation for personal and/or family history of cancer. And so for some people, finding an explanation for why they developed cancer or why they have a strong family history of cancer can be very important. But it's important to note that results of cancer genetic testing do not tell us whether someone has or does not have cancer. Instead, it just tells us about the person's risk of developing cancer. Now, guiding medical management can happen in a couple of different ways, and first is risk-reducing surgery. So some individuals consider surgical options which would significantly reduce the risk of developing cancer. And examples of such surgeries include removal of healthy breast tissue through a surgery called prophylactic mastectomy. It can also include things like removal of the ovaries and uterus preventatively. And the goal of such surgery is cancer prevention through removing the organ which is at the increased risk of developing cancer. But this option may not be available for all cancer types, such as pancreatic cancer and brain tumors. So you can't remove all organs prophylactically. And again, these options may not be recommended for everyone. So the options for risk-reducing surgery, those decisions should be made upon thorough discussion of risks, benefits with the healthcare provider. Another way genetic test results can help guide medical management is through increased screening. So everyone who is at a higher risk of developing cancer may not choose preventative surgical options. Some may choose to meet with a specialist to develop a personalized cancer screening plan. And examples of such screening include addition of breast MRIs to routine mammogram screening, having colonoscopies more frequently, more often than what would be recommended for someone in the general population. And oftentimes, such increased cancer screening begins at early age, at a much younger age than recommended for someone in the population who doesn't have a hereditary cancer syndrome. And the goal of this is to be able to detect cancer at an early stage, which leads to better outcomes, better prognosis for that person. Again, this may not be the most ideal way to go about managing the risk for each type of cancer. So again, the effectiveness of these screening strategies in early detection should also be discussed with your healthcare providers before you choose to do so. And another way it can help guide medical management is through medication. So some people may also be eligible to take certain medications that have shown to prevent cancer or reduce the risk of developing cancer. So individuals at a higher risk may choose to meet with specialists to discuss some of these options with them. Okay, another one is guiding treatment and surgical decisions. So if someone with a hereditary cancer syndrome has already been diagnosed with cancer, certain drugs, treatments have been created to fight cancer cells while doing minimal damage to normal cells in the body. And these are called targeted drugs or targeted therapies. So this essentially tells the physician whether the person who's being treated is likely to benefit from a specific therapy or will they not benefit from that specific therapy. And then when it comes to surgical decisions, individuals who have certain germline mutations may have a significantly higher risk of developing a new cancer of the same type. So for example, if their individual has been diagnosed with breast cancer, and through genetic testing, they are aware that there might be a higher risk of developing a new breast cancer, they may choose to have a more extensive surgery, a more prophylactic surgery than they would have chosen if they hadn't had genetic testing. And this is the last, but a very important category. So that's to identify at-risk family members. So parents, siblings, and children have a 50% or a half a chance to have the same mutation that's identified in that individual. Additionally, other extended relatives on both sides of the family are also at risk of having the mutation. So it's really important once a genetic condition is identified to share those results with family members. And essentially, sharing these results can empower your family members to make their own decision about whether they would like to know about their genetic status or not. And so it's important when you're thinking about sharing these results, sort of not to assume that they would not want to know. And even not to assume that if you've shared it with a couple of people that almost everyone in the family knows. So it's important to share these results with everyone. And it can assist the individual who's been identified to have the mutation, as well as other family members, in making appropriate reproductive decisions based on their genetic status. Okay, so this is the last part of the talk today. This is just a hypothetical case example talking about a very specific hypothetical individual, instead of just looking at her journey of her coming into a clinic, talking about her risks and recommendations. So it's just an example of how it would look like for someone to have a hereditary cancer syndrome. Okay, so Sara is a 38-year-old woman who is meeting with a genetic counselor at the Smilow Cancer Genetics and Prevention Program. And she's coming in because of her family history of cancer. And so this is her family tree. I'll orient everyone to the family tree. So circles are females, and the arrow is pointing towards Sara. Squares are males. Individuals who have been shaded have had cancer of some type. And if they have a line passing through them, they've passed away. So when Sara comes in, she discusses her family history, and she reports that her mother was diagnosed with pancreatic cancer at age 49. And her maternal grandmother was diagnosed with breast cancer at 50. She also reports that her maternal uncle was diagnosed with breast cancer at 70, and she has a maternal first cousin who was diagnosed with prostate cancer at 55. And unfortunately, all of these relatives who are affected with cancer have passed away. And Sara is wondering if she has any inherited risk of developing some of these cancers. So the genetic counselor discusses the family history with Sara. As we saw, she discusses some of these hereditary cancer syndromes that the genetic counselor is suspicious of based on the family history. And then the genetic counselor also discusses the variety of genetic testing options that we reviewed a few slides ago with Sara, and also discusses the benefits and limitations of genetic testing in detail. So after reviewing and understanding all the information, Sara decides to proceed with genetic testing. And Sara's genetic test identifies a mutation in the BRCA1 gene. BRCA1 is just the name of the gene. Some people might have heard of that as the BRCA1 gene as well. And so once Sara has these results, she's wondering, what are my options now? What are my risks? What are my recommendations? So just wanted to circle back and remind that Sara is a previvor. So this is the kind of patient who we would refer to as a previvor, since she has no personal history, but has a higher risk of developing cancer. So the genetic counselor talks to Sara about her cancer risks that are associated with having a BRCA1 mutation. And we also sort of compared them to the general population risk, so Sara can understand how much is that increase in her risk on having this BRCA1 mutation. So women who have a BRCA1 mutation have about a 60 to 75% lifetime risk of developing breast cancer, as compared to the general population's risk of about 12 to 13%. And we do know that in women who have already been diagnosed with breast cancer, we see a higher risk of developing another new breast cancer that's totally unrelated to the one that someone was diagnosed with previously. And this new breast cancer can happen in the same breast, or it can happen in the opposite breast. Now, the specific risk of developing the second new breast cancer, it's certainly dependent on multiple factors. One of them being the age at which the person was diagnosed with their first one. So younger the age of diagnosis of the first breast cancer, higher the risk of developing the second new breast cancer. In addition, women with BRCA1 mutations are also at a higher risk of developing ovarian cancer, and that risk can be up to 40 to 60% lifetime risk, as compared to the general population risk of about 1 to 2%. So ovarian cancer is super rare in the general population. I would like to highlight that both males and females have risks of developing cancer with the BRCA1 mutation. So males have a slightly elevated risk of developing male breast cancer. We also see a higher risk of developing prostate cancer in men. And these cancers are more likely to be aggressive as compared to the usual indolent, slow-growing prostate cancers that we might see in the general population. For both men and women, we also see a higher risk of developing pancreatic cancer and an elevated risk of developing melanoma, which is a type of skin cancer. And so now Sara's heard all the risks, but she's wondering what she could do about this. So in terms of recommendations for breast cancer risk, she can sort of think about different options. So one is beginning annual mammograms along with the addition of annual breast MRI screening. And typically mammograms begin at the age of 40 and Sara's 38, but she would be recommended to begin the screening now because screening does begin at a much younger age as compared to the general population. Sara might even discuss medication options to reduce her risk of developing breast cancer. And she could consider removing healthy breast tissue through prophylactic mastectomy. In terms of ovarian cancer risk, the recommended option for Sara would be removing both her ovaries and fallopian tube. And the recommended age to do so with a BRCA1 mutation is between the ages of 35 and age 40. If Sara does not wish to pursue a risk-reducing surgery for ovarian cancer, she is recommended to discuss ovarian cancer screening options. However, it's important to note that in cancer types like ovarian cancer, the effectiveness of detecting those cancers at an early stage is limited. And that's the goal of screening, is to be, detecting these cancers at an early stage. Therefore, the recommended option would still be to remove the ovaries and fallopian tubes. In terms of melanoma risk, Sara could consider having annual dermatology exams. And then in terms of pancreatic cancer risk, this is where we don't have routine clinical screening available for pancreatic cancer, but there are certain screening protocols or screening options available for pancreatic cancer through investigational and research protocols. The eligibility for this screening does depend on certain factors, such as the age of the individual or the presence or absence of the family history of pancreatic cancer. And so with Sara's family and her mutation, she would be eligible for consideration of pancreatic cancer screening at age 50 after discussion of that option with the specialists. And then lastly, it's important for Sara to share information with her relatives. Sara's children, siblings, parents, they are at a 50% risk to have the mutation. And looking at the family history, it would appear more likely that Sara inherited the mutation through her maternal family. However, that hasn't really been proven yet. So until that's established, it's really important to share, for Sara to share her results with both sides of the family, so both sides of the family can have their own genetic testing. And we would also discuss with Sara that it's recommended that her children and even other children in her family wait until age 18 to pursue the testing for the BRCA1 mutation. And that's very much so because we don't know at this time of any childhood onset cancer risks associated with having a BRCA1 mutation. And the screening doesn't begin until one turns 18. So it's important for children to kind of have that autonomy to make their own decision when they turn 18 on whether they would or would not like to know this information. And I wanted to highlight that Sara's male relatives who test positive or have the BRCA1 mutation would also be eligible for discussing screening options for melanoma and pancreatic cancer. And additionally, they would also be recommended to have annual breast cancer screening through having breast exams and also prostate cancer screening. And some individuals with BRCA1 mutation in Sara's family may be even interested in family planning options that can prevent the mutation from being passed down to their children. And so sharing this information is going to empower her family members to make all of these decisions for themselves. Okay, so that's it for the talk. We have our contact information on the screen here, and the floor is now open for questions that may have come in.
Tanaya, thank you so much. That was a very informative talk. We do have some questions. So one of the first questions is, related to if you've already had genetic testing for hereditary cancer and maybe how often that testing needs to be updated, or whether or not a patient could expect that a laboratory or a genetic counselor would be reaching out to them again if additional testing is indicated, or whether that patient should reach out themselves.
That's a great question. We actually see a lot of patients in our clinic who have had previous genetic testing. And typically, patients do reach out themselves to see if they need updated genetic testing, or they might even discuss this with their clinician to see if they would be eligible for updated genetic testing. But the updated genetic testing sort of depends on when you had your first test. So there are a few factors here. So first is, if you've had your test several years ago, when maybe the testing wasn't as comprehensive, maybe you were not really tested for all the genes that are relevant to your personal or family history of cancer, we would discuss the option of updated genetic testing. In terms of how often genetic testing would be indicated or updated genetic testing would be indicated, I think that depends too. So again, if you've had testing maybe in early 2000s, then you might be eligible for updated genetic testing because the testing back then wasn't as comprehensive. But maybe if you've had testing in 2020, that's more recent, and maybe we just don't have as much newer information for you to kind of think about updated genetic testing. So anytime there's a question like this, I would encourage to bring it up to your provider, meet with a genetic counselor, just sort of have a baseline consult and say, hey, this is the testing I've had. This is my family history. These are some of the updates in my family history or my medical history since I had that prior testing. And that genetic counselor would be able to discuss if you've had everything you really needed to do, or if there's updated options available for you.
Great, thank you. And we had a question in the chat about when you were referring to pancreatic cancer being associated with mutations in the BRCA genes. Were you referring to a primary pancreatic cancer that starts in the pancreas, or were you referring to cancer that has metastasized to the pancreas from somewhere else?
Yeah, so all the cancer risks that we saw, including the pancreatic cancer, they're all primary cancers. So patients are at risk of developing multiple new cancers. So that would be a primary pancreatic cancer.
And a few other questions related to variants of uncertain significance. So maybe you could just kind of define quickly what those are, and then maybe talk about how those can eventually become reclassified and how people might learn of that reclassification.
Yeah. So just taking a step back, we all looked at what genes look like. They are a long stretch of letters. Almost think of that as a sentence in your body or an instruction that your body is reading, and it knows how to function. And we sometimes have variations in our body that the lab just doesn't have too much information about because not every variant causes disease. Some variations are there in your genes that just make you unique, different from someone in the population. And so sometimes when labs don't know whether that variant is actually increasing the risk of cancer, or if it's just a benign variant, something that just makes you unique and different and is not increasing the risk of cancer, they define it as a variant of uncertain significance. What's important to note is that we actually do not use variants of uncertain significance to change medical management. And the reason is that over time, these labs work hard to reclassify those variants. So over time, the interpretation of that variant changes as the lab gathers more information about them. And majority of the time, so you could say close to 90% of the times, these variants of uncertain significance just go back to being benign changes, harmless. And so we, when that reclassification does happen, different programs have different ways, but patients are typically notified, or patients can keep sort of be in touch with their ordering provider to see if there are any updates. But basically, variants of uncertain significance are treated as clinically negative results where we don't really make any recommendations based on those.
Great.
I will add, sorry.
No, go ahead.
I will add the other side though, that there is a small percentage of variants of uncertain significance that can be upgraded to mutations where they have enough data to say, oh, this is actually increasing the risk of cancer. And so it's important if you've had prior genetic testing and you have a variant of uncertain significance, to just keep in touch with the providers to make sure that you have the most updated information about it.
All right, so switching over to Dr. Giri. Dr. Giri, could you talk a little bit about, for patients who have had cancer already, are there certain things that they can be doing to help reduce their risk of a recurrence of cancer or preventing new cancers?
Sure. And this goes back to a lot of the information, that already that Tanaya brought up as well. And, I also saw there was a question about stress and, kind of impacting cancer risk, or does it lead to the development of cancer? So for one thing, if genetic testing has been done and a genetic change, the mutation, pathogenic variant is the more sort of updated term for that, has been found, then one of the most important things that a person can do, even if they've had one cancer, is to engage in screening for additional cancers that could have been the risks could have been identified. So for example, for somebody who might have a BRCA1 gene change, that like a mutation in that gene, if they've had one of the cancers, such as say breast cancer, they should also be talking with a gynecologic surgeon about what is the ways to think about reducing risk for ovarian cancer. They could also, if there's a family history, certainly of pancreatic cancer, potentially meet with a gastroenterologist to talk about what are the ways of screening for pancreatic cancer, and also meeting with the dermatologist to talk about the more in-depth skin exam that might be needed to look for screening for melanoma. There again, a lot of the common recommendations that are made. So for example, reducing direct sun exposure, wearing sunscreen becomes so important, in terms of reducing the melanoma risk. Other things to think about really are linked to other healthy lifestyle factors. So, no smoking, moderate or limited alcohol consumption, a healthy diet, appropriate activity in lifestyle. All of those things really matter. And they matter because it's important to think holistically as well as we go forward. So, that becomes important not only for reducing cancer, potentially reducing cancer risk, but then also for heart health, and things like that, which also are really important. And for this question about stress, there's a lot of research that's going on about the sort of biologic role of stress in cancer development or maybe cancer progression. There are some mechanisms linked with that stress can reduce immune function, and potentially that can maybe lead to some cancers arising. But overall, it's not like it's definitive, in the sense of stress leading to cancers. But what can happen is that when somebody is stressed, they may turn to smoking, or they may turn to drinking excessively, or they may turn to other sort of factors that could raise the risk of cancers too. So I think it comes really back to someone's having trouble coping with anything, or the stress levels are rising, is potentially reach out to be able to address the stress itself, because it's so important from a holistic standpoint.
Great, thank you. And Tanaya, I know we've been talking a lot about the importance of family history, but some people, for a myriad of reasons, may not know their family history or may not have a complete family history. So what should those individuals do when they're thinking about whether or not they should pursue genetic testing?
So I think we do see a lot of patients, or maybe not a lot, but we do see few patients where they maybe don't have information about few of their relatives, maybe the entire paternal side of the family, or maybe their entire family altogether, especially if people are adopted and, they don't have a lot of information about their biological relatives. So when we talked about red flags, some of them, we do look at the family history to assess for those. So it might limit some of our assessment. but we work with the information we have. So in fact, sometimes not knowing about the family history could be another motivating factor for people to have testing. And it's very normal to not have information about every relative in the family. So we'll sit with the patient, sort of discuss what are the limitations of the information we don't know about your family. What can we do with the information we do know about your family and yourself? And so this assessment can be very individual to each patient we meet. And so not having family history certainly should not be a barrier to seek genetic counseling.
Great. And then another common question is related to insurance concerns with genetic testing. Could you just talk briefly about some of those concerns and maybe provide some information to people about what to consider?
Yeah, so we do have a federal law at this time, which does not allow discrimination by health insurance companies and employers based on genetic information. There are a few exceptions to it, such as having insurance through Veterans Administration or being employed in the military. But these protections that we have against health insurance discrimination and employment discrimination, they don't necessarily extend to other types of insurances, so specifically life insurance, disability insurance, and long-term care. So these companies can actually legally deny these coverage or could increase premiums for certain individuals who they know have a higher risk through genetic testing. And so some people actually might choose to look into some of those things first, insurance policies, before they actually go and move forward with genetic testing. So certainly something to consider while you're looking at this option.
Great. And then Dr. Giri, are there certain resources that might be available to people who have an inherited risk for cancer that you wanted to make them aware of in terms of either at the Smilow program or nationally?
Yes, it is really important to know what is available out there to help whether patients have cancer or are at risk for cancer for informational purposes. And so the Smilow Cancer Genetics and Prevention Program has a website under Yale Medicine as well, and that has information that covers the various different cancers, options for genetic testing, and is a resource that is available as well. Other national resources include, for example, the FORCE website, FORCE. This is a website that is an advocacy. So this organization is an advocacy organization, and they cover lots of different genetic syndromes, and also have brought in resources that are additionally, national resources to link in for patients to have access to. Another website also would be from the American Cancer Society in terms of the lifestyle factors that can be addressed to reduce various cancer risks. And they have a nice patient-friendly version of a lot of this information. So they do an update every 5 years of the literature and make recommendations based on that. So those are just a couple of the resources that are available. And I think it's really important to go to expert resources where the experts have looked at the information that's out there, because there can be some misinformation, of course, on the internet. So better to stay with reputable sources and organizations.
All right, well, I think we've reached the end of our questions. So thank you both again for your talk tonight, and thank you everyone for attending. And if you have any questions, the contact information for the program is there on your screen, and feel free to reach out.